Bom dia a todos. Abrindo esse encontro da Abril Chamber, a Câmara Brasil-Israel de Comércio, hoje um evento muito especial, não apenas para a apresentação de tecnologias inéditas em healthcare de Israel, mas especialmente por seu evento de posse do novo diretor da Abril Chamber na Regional do Paraná, fabuloso. A Abril Chamber, dentre suas metas, estabeleceu a abertura de câmaras regionais pelo Brasil e dar também um incremento para aquelas que já estão funcionando há mais tempo. A do Paraná, aberta ainda na gestão do ex-presidente, nosso amigo, nosso presidente de honra da Abril, Jaime Blay, e que está presente nesse evento. Queria agradecer a presença do Jaime. E hoje dá a posse ao novo diretor regional, fabuloso, profissional competente, conhecido, respeitado, e que tanto nos orgulha de tê-lo no time da Abril. Fábio, em nome da diretoria da Abril, do Conselho, do Jaime Blay, nosso ex-presidente, e de todos os associados, desejamos o maior sucesso e boa sorte a você nessa gestão. E, a partir de agora, a palavra é sua, o comando do evento é seu, você está na sua casa, no Paraná. Muita sorte, assume o comando desse evento também. Muito obrigado.
Renato, muito obrigado pelas palavras gentis, muito obrigado pela honra em me convidar e fazer com que eu seja nomeado o diretor regional da Câmara Brasil-Israel de Comércio e Indústria. Eu tenho certeza que aqui no Paraná vocês encontrarão um local muito legal e os nossos empreendedores, tanto os paranaenses que pretendem fazer negócios com Israel, tanto os israelenses que pretendem fazer negócios aqui no Paraná, serão muito bem-vindos e serão recebidos com muito carinho. If you allow me, now I'm gonna start the event. I would like to introduce our speakers. We have the honor to have today two guests. The first one is Mr. Yaniv Kotler. Thank you for being here, Yaniv. Yaniv is a biotech entrepreneur. He's the CEO and founder of Genie From Limited. He's master in laws and finance, and he founded and he was also the president of COVAX Limited, which is an USDA approved fish vaccines manufacturing. And he also served in various executive roles for 25 years. I would like to introduce as well our second guest, which is Mr. Itzik Levy. Since 1991, Itzik served as an IT professional in different capacities. Most of his career, he was employed by the private sector in senior technology management roles. And he also served as a VP projects in a few IT integration companies, specializing in delivery of digital projects to the leading companies in the Israeli market, and then as a CEO of an Israeli fintech startup. Itzik also has an extensive experience in the public sector since he worked at the Israeli Ministry of Health and managed the national digital project sector. In this last role, before joining Umanu, which is the company where he's the CEO since 2020, he co-founded a digital health startup that focused on collaboration between patients and care teams to disrupt the way patients' care plan is managed. So we have here today with us two healthcare specialists. And I'm pretty sure that we are going to hear about innovation, about disruptive ways to handle the pandemics. And this is the reason that without any further delay, I would ask Yaniv to start with his presentation. Yaniv, you have 20 minutes. then I'm gonna pass the word to Itzik, and we are going to have Q&As. I would like to invite our audience to submit questions both on YouTube or also using our broadcast platform. Yaniv, the word is with you.
Thank you. Thank you. First of all, thank you very much for the opportunity to present our company. And it's I really want to visit in Brazil. You know, the corona made it very difficult for us, and we want to go abroad whatsoever, and Brazil is one of the first places. The festival is coming soon. I want to share my presentation. Can I? Is it shared?
Not yet.
You have to
Okay,
share
just
it.
a second. We are managing to.
Doesn't take it. Renata, can you help me?
Can you share your screen again, please?
Oh.
If you can share your yes. No, it's gonna work.
This okay now?
Yes. Yeah, it's okay. Go ahead.
Okay.
Thank you.
Okay, so Jinfon is a company for personalized medicine. We are treating autoimmune and viral infectious diseases. This is our field of interest. And we are looking at prognosis for these kind of diseases. And I will immediately go a little bit into what we are doing. The company is already 10 years old, and it's selling in the Israeli HMOs, and it's also doing in South Africa and Belgium a little bit of its products, and I will present them, please, during this this talk. We are looking at the combination of actually math and and molecular biology. We are looking through proprietary algorithms to see various genetic or RNA signatures. Usually it becomes RNA and not genetics, or not DNA. And we are looking to see, we are centering the patient needs in our focus. Actually, we're looking for the best treatment or prognosis that we can give per patient, per disease. So we need always this combination of a patient, a disease, and an answer, a treatment, or an answer in prognosis in viral diseases. Let's just start for an example in the autoimmune selection of biological treatments. Currently, a patient, when he needs a biological treatment, for example, Humira, Umbrella, or an anti-TNF, or whatever, he goes to the physician, and the physician selects one of the treatments that he can give. It could be anti-TNFs, it could be IL-6, it could be anti-B cells, whatever. And then he goes through a trial and error method. Usually he takes, for example, if it's an rheumatoid arthritis patient, he goes through 6 months to a year treatment. And then according to the results, the physician decides whether the patient is a responder or a non-responder. If he's a responder, everything is well, and he's continuing receiving this medication. However, in the 40% of the cases in anti-TNF, for example, for RA patients, patients do not respond. And then they are going through this cycle again, as you can see that on the picture. Patients that do not respond are not only suffering from not responding, they're also actually blocking a biochemical cascade that it is working well in their body, and they respond bad to the non-responders. It costs a lot of money to the system. It costs a lot of suffer for the patient. Their disease is continuing to deteriorate. They're going out of the work cycle, and all the long-term consequences are imminent. For example, the surgeries of exchanging fractions and so on. So we are looking at, as I said, we were looking for a a method in order to select the right treatment for the patient. And the business idea that we had in our mind was to do it in a local lab, not to do it in a special lab. We were looking for a simple test that almost every point of care lab in the West has it. And we said that we thought that we as a company should do only the final calculation. And the answer is given back to the lab. And of course, it has to be in high accuracy, evidence-based, whatever needs and has to stand in all regulations. So we started from looking at the databases to look what are the differences between people that are responder and non-responder. We took every biological data that we have. As I said, our team is constituted from people that are mathematicians and people that know biology, that are biologists. And we looked at both proteins, RNA, DNA, all kinds of RNAs that we could put our hands on, or DNA structures, whatever, every library in the world that we could find. However, we found most of our answer in our platform, or we developed our platform in the end by selection. I mean, that was the best answers from the RNA libraries. Using this artificial intelligence or this AA platform, we could actually fish a small set of genes that a difference in their expression could say up front if someone will be a responder or non-responder to a certain treatment. So, for example, I'll give you just an example. We analyzed through this AI platform with doing this volcano diagram. This is the diagram that I showed before. We call this diagram a volcano diagram that is showing the difference expression of all the 21,000 genes that we have before and after the question that we're asking. For example, a response to a biological treatment. Since you're taking data sets or cohorts throughout the world, retrospective, that everyone has the access to them, we looked for genes that are overexpressed or overlapping their expression between different cohorts. For example, if a patient is a non-respond, and then he's a respond, we can see in these genes a difference in their expressions. We also looked if these genes are showing a correlation, and on the right you can see what we call a string software analysis, which shows that all of the genes, for example, in RA patients, again, for a treatment of a TNF blockers, are all genes that we selected came from the interferon stimulated genes. So we have actually had the opportunity to develop two kinds of tests. First of all, we'll look only on the bottom test. This is what we are drawing blood from patients. We're looking at the basics of the genes expression that we have fished before, and we could determine whether these patients will be responders or non-responders. And this is the answers that we got in clinical trials here in the Sheba and Ichilov. This is only one cohort of 27 people. We have done 102 already prospective, and we had 250 retrospectives, as I shown before. These you can draw here a line between the groups, and you can actually bring yourself to a very high accuracy to know before if someone will be a responder or a non-responder to a TNF blocker for RA patients in this example. Currently, the random results are around a 40% non-responders and 60% responders. So we are bringing the health system to actually, on every 10 patients, 3 or more are responders now, which is in Israeli money is around 50,000 shekels or $15,000 for the first year saving for the health system. For every year later on, it's around the $5,000 to $8,000 saving. The people that are interested in these kinds of tests are, of course, the insurance companies and the patients. The drug companies are not our best friends, as you can understand from these kinds of works that we are doing. However, even the drug companies are starting to understand that there's no escape from personalized medicine, and you need to cooperate with this. And we are starting now, after sales has begun, to feel some ease from these companies. Now, what we have done, I'll go back just a minute for this one. What we have done, we have now look at the upper diagram. We have looked at several viral disease infections. Currently, everyone in the world is a virologist, and I have to remember that when I talk with the people. But what we have looked at the 2013 and 14, we have taken a hepatitis C virus at the time before, or actually with the new drugs, but that was a very good system for a proof of concept, because it was a dichotomic system in which we looked who will respond and who will not respond to a interferon alpha treatment at the time. The issue is that we took liver samples at the time from people that anyway gave their liver biopsies, so we didn't take it on purpose for us, in a Shiba hospital and in Shaarei Tzedek in Israel. And people were already infected, and the results were overwhelming. We had 99% accuracy, knowing who will be a responder and who will not be a responder for interferon alpha at the time. The random success is around 48%. That was a proof of concept. The next one we went was the CMV for pregnant women. It's like the Zika in Brazil, the same idea. You can know upfront who will transmit the virus and who will not transmit the virus to the fetus, and who will stop it in the mother. And then came the COVID-19, which I would like to present it here because we just used this platform to the COVID-19 to work with. What we have done here, the idea was to try to see who will be hospitalized and who will not be hospitalized before he's infected by COVID-19. I mean, we can take every healthy human being, and say upfront what will be his prognosis, plus minus, with 90% accuracy, as I will show you down immediately. What we have done here, we have taken people, we have taken blood from these people. Some were severely sick, are the red on the right, on the left-handed. I'm pointing it out. These were all people that were sick and hospitalized in Israel during their disease. And the left one, the green ones, were not hospitalized. I want to emphasize that all people here are at least 1.5 months post both 2 PCRs negative. I mean, they were healthy like before. But so that's why we had to do a stimulation. We took their blood, we stimulated their blood as they were sick with viruses, and we looked at these certain genes that are expressed differently between the groups that we fished as we did before. So here you can see that the two groups are very distinct. We have then the rock is on the right. We have then taken people that are here on the blue from the population that were not sick at the time, trying to do prospective, but actually we were a little bit late because immediately after they vaccinated all the population here in Israel for the last half year. But you can see the distribution of the signature that is very nice accordingly to the population. When we looked at sorry, I didn't put it here, but when we looked at the age distribution and the distribution that we had down the streaming, we got to a 70% correlation. So what it means that this signature is very, very much specific to the COVID-19. We can do this to every virus we can. We have published also, and we're selling here for what we call precious pregnancies, a prognostic kit that shows who will be a transmitter or non-transmitter to a CMV virus for pregnant women. We can do that theoretically for Zika virus. We have the signature for the Zika virus that we are keen to develop with someone in Brazil to know upfront who needs an abortion, who will and who will not. This is the technology actually that we have in hand today. We have developed the following applications. As I said, RA, we are for TNF blockers. We can say who will be a responder, who is not. It's already sold in the one HMO in Israel. The second is entering right now, and the third, the biggest one, will probably do it after the two ones are doing it. We're actually holding now half of the population of Israel that is under these tests. We're also checking psoriasis arthritis, or psoriasis arthritis, knowing who will be a responder and who will be a non for the same drug, the TNF blockers. We have developed a multiple sclerosis test for knowing who will be a responder and who will be a non-responder for interferon beta treatment, which is around 20% currently of the patients taking it. The accuracy is around 95%, and the random is 50%. As I said, CMV, I talked about it, and the COVID-19, as I said, it's not going to work for COVID-19. It was sold here very strongly for a very short period of time, and it was given for the very rich people. We took a lot of money for this test because it wasn't industrial anymore. It was a handmade, it was tailor-made for each one. We didn't have the time, but as I said, the population was vaccinated. So we're actually looking in Brazil for two things. One, to commercialize what we have, but we're also, as I said, like in the Zika, we're looking for new projects because we can use our AI platform for much more diseases. And it's probably going to be very cheap in Brazil. Thank you.
Thank you very much, Niv.
Yes, I have to see if there are questions.
Yes, it's a very good presentation. Actually, we are going to conduct our Q&As after Itzik speaks, but it's a very, very, very interesting presentation you just offered us. I would also like to nominate one official that is watching our presentation, the diplomat Paulo Fernando Pinheiro Machado. He's the representative of our foreign relations chancellor here in the state of Paraná. Thank you for watching our presentation. Itzik, I would like to ask you to continue with to begin with your presentation. Thank you.
Thank you very much, Fabio. I'll share my screen now. Can you see my screen now?
Yes.
Yes, you can? Okay,
Yes.
great. So I will be talking about the next generation of telemedicine. I'm Itzik, I'm the CEO of Umano. But I would like to start with a short story. This is Dr. Alon Gur. He's a general practitioner, and he's providing out-of-hours urgent care for the largest HMO in Israel using Umano's telemedicine platform. So this is a story he told me while I was talking to him. So he told me that it was a late night online video consultation he was making with a young mother. She looked very worried and exhausted, and she told him that her little child has high fever and is unresponsive and apathetic. He said, I was ready to send them to the ER right away according to the clinical protocol. We'll return to Dr. Alon and the young mother in a few slides. I'll stop here. So the big questions I would like to discuss is if 50 to 90%, depending on how conservative you are, of doctor visits can be delivered online, why aren't they? And will COVID-19 make the difference? Will it make the change from the numbers that we had before to this new limits? So who am I? I'm, as presented, I'm Itzik. I've been working most of my career in the private sector as a C-level management in various technology companies. About 7 years ago, I joined the Ministry of Health in Israel as the head of the National Digital Project Sector, implementing the vision of the digital health and of the vision of the Ministry of Health with national projects like the National Health Information Exchange platform and the National Big Data platform. Then I became the Chief Digital Officer of Healthcare Israel, which is a government agency doing G2G, government-to-government collaboration. And I had the opportunity and the privilege to be in Brazil, in Sao Paulo and in Rio, working with the government, trying to make collaboration with Joel Formiga, who was at the time working for the Sao Paulo government. Then I became the co-founder of Springia, and for the last year, which was a digital health startup, and for the last year, I'm the CEO of Umano. So the COVID-19 outbreak had a huge impact on the telemedicine industry and telemedicine services. All these graphs are from the Cohen and Company report. We consider that at the beginning of 2020, only about 4% of patient visits were remote, while 96% were in person. By the end of 2020, 17%, still way far from the potential, but much more than at the beginning of 2020, were remote visits, while only 83% were in person. We can see that also from the physician side, 80% compared to 20% had the chance to try video visits. But as I said, this is huge impact, but one, it does not fulfill the full potential. And the other thing we see in countries coming out of COVID, like UK and other countries, US, is that the numbers are starting to drop back. And the question is, will we embrace the opportunity the crisis presents in terms of telemedicine adaptation? And we can see that the number one barrier to the adaptation, even post-COVID-19, is still technology challenges. And here is where I want to start presenting Umano. So Umano is a telemedicine company that uses innovative technology to bring the experience of a real clinic to the digital world. Our platform was built with clinician and for clinician to create outstanding optimization and user satisfaction. We found out that the real technological challenge in telemedicine is not the ability to initiate an audio or video session between a clinician and a patient. This challenge was already solved by off-the-shelf tools like Zoom, Teams, Google Meet, WebEx, and other tools. But these generic tools do not address the pains of the clinicians and the health organizations while trying to provide online consultations at scale. The real challenge is to provide a telemedicine service that is very simple to the clinician, highly available to the patient, and very effective for the organization. Working alongside with medical providers while we developed our platform helped us focus on their specific pain points and to take a unique approach when in the way we provide online services using our platform. And let me tell you why clinicians love using our platform, and they do. It's because when using our platform, when you're using Umano's platform, patients wait for the clinicians, like in a real clinic, not the other way around. We automated all the administrative operations to drive the clinician efficiency up and the costs down. And we enabled predictive queuing to dramatically reduce no-shows. Here you can see some testimonials from clinicians who are using Umano. When working with Umano, I'm much more productive. All I have to do to start the next session is click, no dialing and waiting. The crisp video and the ability of the patient to upload pictures allowed me to provide high-quality clinical service. I'm not a tech savvy, and I really like the fact that Umano is very simple to use without any hassle. So what's in it for a medical provider to use our platform? We drive demand from face-to-face or phone to online consultation, and I mean real online consultation at scale with high-quality video. We provide double-digit saving in operational cost, near zero no-shows. We provide more consultation with less clinicians or even more consultation with the same number of clinicians. We provide full command and control for the medical provider, powerful mechanisms to generate new revenues, and huge boost in customer satisfaction and loyalty, which in fact we measure in periodic satisfaction surveys, both for the clinician and the patients, where we have high scores. So, okay. Now, all these benefits and advantages are not just a vision or a promise. This is already being done in large scale in Israel. We provide out-of-hours urgent care to the largest HMO in Israel, covering 5 million lives. Using Umano, a nationwide network of 170 clinicians, provided over 1 million online consultation in the last years with unheard of efficiency and quality. Each day, we have 3,000 to 4,000 online consultations using our platform, with average waiting time of 20 minutes, and where a new patient is pulled from the queue every 10 seconds. And if you look at a pre-post-COVID case study, these are real numbers when using our platform. You can see it started in January 2020 and up until May 21. You can see that pre-COVID, we had, using our platform, around 46,000. This is monthly out-of-hours urgent care online consultation. In the first lockdown in Israel, which was around Passover, which was March, April, the number jumped to 84,000. Then in the second lockdown, we reached the peak of 96,000 online consultation in out-of-hours urgent care. But the very interesting number is the number that you see just last month, during May 21, with no restrictions at all in Israel, where you can, go to the physically and meet your doctor face-to-face. The number are still high, and we reached a new standard, which is around 83,000 consultations a month, which is almost 1.8 multiple times than what we had pre-COVID. So when you embrace the opportunity that the crisis presents, and you provide the clinicians and the organization with the right technology, then you can actually have the full potential being fulfilled. So, how do we do it? When I say that patients wait for the clinician, I refer to one of the key components in Umano's platform, which is the smart virtual waiting room. When using it, all the doctor has to do is click a green button and the next patient is connected and a new session begins. No need for the clinician to do any dialing and waiting. We make sure that each time the clinician presses the green button, the patient will be connected using automatic predictive queuing mechanism. This mechanism autonomously calls the patient and connects him while optimizing the patient waiting time and without any human operator involvement. If the patient is not available to accept the call, the system will call the next patient and then return to the previous. If the patient cannot start a video call, the system will start an audio call. All is done autonomously and totally automatically. Another example of operations automation is the full self-service functionality we provide a patient. So all the patient has to do in a walk-in or on-demand scenario is press a button and put himself in a queue. And in a scheduled appointment scenario, he can set up his own appointment with the physician. There's no need for a call center, and there's no need for the clinician to do secretary work. We value the optimization of the clinical workforce very much. So we use Uberization and automatic rescheduling capabilities to make the best out of the most valuable resource, and that is the clinicians. These capabilities allow us to automatically make adjustment to the scheduled appointment according to the dynamic availability of the clinician. I'll tell you a little bit more about it in the next slide. And we provide an admin dashboard that allows the sysadmin to get the full real-time online picture of what's going on with all the services that are being delivered using the system. It means that the sysadmin can at any time see how many doctors are currently providing services, what's the average time of a service, of a consultation, what's the average waiting time, specifically right now in this specific shift. And all this information is available online in real time for the sysadmin. So our platform supports, as I was starting to say, the two common operational models, on demand, the one we have at the bottom of the slide, on demand walk-in scenario, mostly used for urgent care, and the scheduled scenario, which is mostly used for primary care and secondary care. So while in on-demand walk-in scenario, all the clinician has to do is to check in for a shift and start pulling patients from a queue. As I said before, they put themselves in a self-service, the patient put themselves in the queue, and then all the clinician has to do is to pull them. In a scheduled appointment operational model, the synchronization is much more important. And here we have the automatic rescheduling mechanism to help us overcome the dynamic daily agenda of the clinician and to optimize their time. So if the clinician is on time, as you can see here, then the appointment will be held on schedule. If the clinician is late, the system automatically outreach the patient and postpone the appointment to a next available slot. But in the case that there are more clinicians available than were planned, so if a clinician now has time and he wants to jump in and get some appointments, the system will automatically bring forward later appointments. It will outreach the patient, ask him if he can receive the service now. If not, the appointment will be held at the original time, But if it can, it will bring it forward and will actually optimize the clinician time and the patient time. So all this is being done automatically. When developing and deploying Umano's platform, we took what we call a whole system approach. It means that you can start using the system with a specific care setting, let's say urgent care, but it has all the capabilities to provide all the other care settings like primary care, secondary care, social care, and maybe others. And its sysadmin can at any time, the sysadmin, when using our system, can at any time configure new service. It doesn't need any software developer. It just uses our self-service configuration tools, and he can configure new service. Like, let's say he was using only urgent care, on-demand urgent care, and he want to add a new service and onboard new clinicians to provide the service. Doesn't need any software developer. It's just using the customization tools, and you can put a new service in production within minutes. So, and I try to be not to be too technical, but just in very high level, this is the platform, and let's have a quick peek on what's inside the box. So on the left side, we can see we have a white label, what we call digital clinic. It's white label application for the patient and a white label application for the clinician, where they conduct a consultation and they work on their own term, etc., etc. On the right side, we have the white label application for the administrator, where we have the operator that monitor and manage the system, and the admin that create new services, onboard new clinicians, create new contracts within the system. And all these applications, which are both can be used on desktop or on mobile devices, are on top of the smart engines, which handles the authentication, business process management, eligibility, media servers, etc., etc. Here you can see some screenshots from the clinician's application, where he can manage his appointment list, appointment detail, have a multi-channel conferencing, audio, video, etc., and even do the summaries, referrals, and e-prescriptions that he can send directly to the pharmacy. This is the patient application, the white label patient application, where he can schedule appointment, where queue and wait in this virtual queue that I mentioned. He can upload different kind of media, pictures, documents for the doctor to see during the session. Upload of media could be a prerequisite that the system administrator could configure, that the session will not start unless the patient uploaded pictures of or documents, and of course the multi-channel consultation. And here we have the screenshots of the admin console, where the administrator can configure new services or monitor and watch the system. So what's in it for the providers? As we said, automated complex manual operation, less clinician for more demand, drive demand from face-to-face to online, double-digit reduction in costs. For the clinician, patients wait for you just like in a real clinic, automatic rescheduling to optimize your time, near zero no-shows. And for the patient, shorter waiting times, no need to leave home, and you can see the clinician over a video just like face-to-face. So to sum up, Umano is a game-changing telemedicine platform used by huge health organizations, providing to millions of lives, facilitating over 1 million remote visits a year, with predictive queuing to achieve near zero no-show and huge cost saving, and powerful mechanism to create new business lines. And just for our story, to finish our story, so we were with Dr. Alon, with the worried mother, and he was saying that just before sending the ER referral, he asked the young mother to turn her phone's video camera to her child. And then I saw him running around in the room, smiling, totally responsive. And instead of going by the protocol and to give her a referral to ER in the middle of the night, all I gave them was e-prescription to paracetamol, and that ended this session. Thank you very much.
Thank you very much, Itzik, for your presentation. And the last phrase used, I believe it's very appropriate here in Brazil, since we are having our hospitals full of people due to the COVID pandemics. Physicians are already using telemedicine authorized by our authorities, because before the pandemics, this kind of online consultations was prohibited. So with some bad situations, technology can promote changes, and this is something that we are noticing during these very sad times. So I would now start with our Q&As. I selected a few questions. The first one is for Yaniv. I believe you already answered that during your presentation, but just to make it very clear about the possible usage for the testings, for the prediction tools. Which kind of disease, like you mentioned COVID, you mentioned other kinds of diseases, but specifically, which kind of diseases you have now being treated with your tools? Oh, your mic is off.
Sorry, I shared my screen again. Renata?
Okay, Renata, if you can. Okay, thank you.
I just want to put it here. We can do anti-TNF for a RA patients is the best one. We can do it all for psoriasis, arthritis, and for a SLE, what we call lupus, patients. What we can see here in the diagram is like, for example, 292 retrospective lupus people that have the anti-TNF signature, genetic signature high, which the treatment, can reduce them. This is the anti-TNF. By the way, this is the control. These are the healthy people. I just want to show this is we did publications for RA patients for anti-TNF. It's a peer-reviewed one. Could be read. I could send it to people that are interested. This is the CMV publication that we are doing it also. And again, what we're looking is not only what we are doing here today here in Israel, because Brazil and Israel have different kinds of needs. I'm sure that the Zika virus interests more in Brazil than in Israel, since we don't have Zika. But I think that you can save a lot of suffer money if you will know which mother needs an abortion and which mother will not need an abortion. Again, but if we're looking at autoimmune diseases, we are in the best in the RA. We have the signature for Crohn. We have the signature for IL-6, for anti-interleukin-6 blockers for RA patients and the psoriasis hepatitis when they are given. Not always. MS, we are now looking at the new drugs that are coming in, Guinea, so on, Guinea. So this is what we're in the field of autoimmune and viral diseases, and most of the biological treatments are there. I have here on the right questions. Should I answer them or later?
Okay, thank
Fabio,
you.
should I answer?
Yes. Well, there is another question. Actually, the question is for both of them. Who buys the technology and what's the price model? In essence, it's the purpose of this meeting, both to inform about technologies and also to start a business relationship between Israeli investors, scientists, and entrepreneurs, and Brazilian peers. So, what's the idea? In essence, what's the idea and what's the price model for the final customer?
Can I continue?
Yeah, sure. Go ahead.
We are selling, as I said, we are selling to 2 HMOs, and I believe it's not the HMO that Itzik is selling to, as I heard. There are only 4 here in Israel, so we all know one the other. We are taking one half of the population. He's taking the other half. But it's funny. But the people that are we are giving benefit for 2 sections in the for 2 business sections. One is the providers, the people that pay money for health services. We are saving money for them. People that don't need a certain treatment, and I wish I could do that by telemedicine like Itzik is doing it, but I can't. I have to take blood and I have to look at the genes and I have to calculate them in the end. And the model business that we are working, that it's supposed to be in the local lab. Our company, GenePhone, is only doing the calculation in the end. So the lab is in Brazil, the blood taking is in Brazil, all the elements are in Brazil, and we're doing only calculations. So it's used. Moreover, it's also sold in South Africa and Belgium, and it can be used. In addition, we are looking for doing collaboration with the Brazilians, the physicians, and the health providers for expanding the platform for issues that are very interesting in Brazil.
Okay, thank you. So, in essence, it's hard to say, to mention like a final price to a customer, since it
exactly, because it seems
on the partners, on
exactly the Brazilian lab will probably secure the their own price for making the money.
So we are looking for potential labs here in Brazil, or hospitals, institutions that can partner with the services you provide. That sounds fair. Okay, Itzik, about your model, what you are envisioning, and who you are looking for to.
So our customer or clients would usually be healthcare providers. It could be hospitals. It could be clinics or GPs. Actually, we work with a Brazilian partner, which is IL Health. We work with them, and they are our partner on the ground in Brazil. I would say that we have 2 pricing models. One of them would be pay-per consultation. This is the way we work in Israel. It's pay-per consultation. And the other model is what we call PMPM. It's per member per month. So it depends on the customer. He can choose one of the 2 models, depends on his operational model and his business model. We're looking to be, where we benefit together. The patient, the customer, the provider will benefit from using the platform, and we will benefit. So we're flexible in the way that in choosing the right business model for the client.
Okay, so thank you very much. I would like to invite our President of Honor, Jaime Blais. I'm very honored to have you here, Jaime, in my appointment. Please, I would like to have your comments, your thoughts, the words with you, Jaime.
I will say it first in Portuguese and then I'll switch to English, ok? Fábio, é uma enorme alegria ter uma pessoa como você no cargo de presidente da nossa regional no Paraná, que é um estado extremamente importante, tem uma enorme parcela de trabalho junto com Israel, tem recebido um enorme apoio nas suas atividades e você certamente será um motor de impulsão para que novos negócios, novas relações surjam. Eu te desejo o melhor possível, saiba que estamos todos aqui na torcida para incrementar essas relações entre agora Paraná e Israel também, e estamos à disposição para o que for necessário.
Muito obrigado, Jaime.
Passar um pouquinho para o inglês. Dear professors, it was an enormous pleasure hearing you and the exposition, and we have so many to benefit from the developments that have been done in Israel recently, that I can only thank you very much, and I hope that with our work here in the Brazil-Israel Chamber of Commerce, we'll be at your entire disposal and be willing to help and to let you introduce as many new developments as possible in order to increase the standard of life here in Brazil, to make this the health problems in Brazil that are really very, very tough for people to handle with. And I hope that our cooperation that lasts for more than 60 years, this is the time frame of the Brazil-Israel Chamber of Commerce. We were betting in this partnership for a long time, and the fruits are coming, and in very intense way. We have more than 200 Israeli companies working here in Brazil, and I hope that we'll go on and on and on with the new president, Renato Oshman, that I'm very proud. I had Renato as my vice president. Now I'm very proud to have it as the president, the young president, fabuloso, and we are all at your disposal. Thank you very much to all of you.
Thank you.
Okay.
Thank you so much.
Thank you very much for your presentations. I'm seeing Renato again here. I would close the session, but I believe since our president Renato is here, so Renato, if you can close our session, I would appreciate it.
Thank you, Fábio. Well, Yaniv, thank you very much for joining our event. It was a real pleasure to have your presentation, your thoughts, and your informations. It was very helpful for us. Fábio, mais uma vez, boa sorte nesse desafio. Tenho a total certeza, e a diretoria inteira tem total certeza e confiança em você, que eu sei que nós vamos incrementar muita coisa nas relações entre Brasil e Israel. Jaime, obrigado pela sua presença aqui, como sempre, nosso presidente de honra, e eu queria agradecer a todos por mais uma vez presentes em nossos eventos, e em breve nos veremos com mais eventos entre empresas israelenses e brasileiras. Muito obrigado a todos.
Obrigado.
Bye.